How to manage diabetic ulcer? So consult the doctor if you notice any of these symptoms: tingling or burning or pain in your feet, a change in color or temperature of your feet, dry cracked skin on your feet, loss of feeling or ability to sense heat or cold, toe yellow lines, and loss of hair on your toes and feet and lower legs, and a fungus infection such as athlete foot between your toes, and an ingrown toenail or a sore such as blister, ulcer, or infected corn. Pathogenesis is normal food that sustained hyperglycemia will result in abnormal immunity aggravated by angiopathy, and neuropathy will result in infection. What is neuropathic food? Neuropathic food has diminished sensation. It is invariably warm with intact and often bounding pulses. Ulcers are the pressure points on the plantar surface and stress areas on the dorsal surface. Ulcer preceded by callus formation, and ulcer can be secondarily infected and quickly leads to cellulitis, abscess formation, and osteomyelitis, and sepsis may complicate, resulting in gangrene. Ischemic or neuroischemic ulcer, foot pulses are absent and foot is not warm, and lesions on the margins of the foot and tip of the toes. Absence of callus is the characteristic feature. Gangrene may be present and essential to identify critical ischemia. Characteristic: pink, painful, pulseless, cold foot. Skin temperature is cold in ischemic ulcer, warm in neuropathic foot. Neuropathic is painless and ischemic is painful. Ischemic pulses are absent and bounding pulses in neuropathic foot. Callus absent in the ischemic foot and present in the neuropathic foot at the pressure points. Management of neuropathic ulcer fall into three parts: removal of callus, eradication of infection, and reduction of weight-bearing forces, often requiring bed rest and foot elevation. Excess keratin should be pared away with a scalpel blade to expose the floor of the ulcer and allow efficient drainage of the lesion. Neuropathic foot X-ray radiograph to assess the possibility of osteomyelitis. A deep penetrating ulcer is present when lesions fails to heal and it continues to recur. Then we can do the X-ray. Bacterial swab should be taken from the floor of the ulcer and culture of the excised tissue, and superficial ulcer may be treated on OPD basis. Oral antibiotic are prescribed according to the organism on the culture, and most likely organisms to be infected in superficial are staph, staph, and anaerobes. Treatment should be started with amoxicillin, fluoxetine, and metronidazole. Antibiotics should be adjusted when results of bacteriological cultures are available, and choice and duration of antibiotic administration require considerable expertise and laboratory guidance. Neuropathic foot deep indolent ulcer requires offloading with total plaster cast, and it should confirm the contours of the foot, thereby reducing the shearing forces on the plantar surface. Any foot lesion which has not healed in 1 month requires further investigation and different approach. Ischemic foot ulcer doesn't respond to medical treatment, and vascular investigation is usually required. Doppler studies to measure the pressure index, ankle brachial ratio of systolic blood pressure. 1 to 2 indicates rigid or calcified vessels or both, and 1 is normal, and zero point 0.9 indicates ischemia present, and zero point 0.6 indicates severe ischemia. Amputation of the toe is usually unsuccessful until it is revascularized. If this is not possible, then dinecrotic toe should be allowed to auto-amputate. After attempts to control infection, below-knee amputation is indicated in those with extensive tissue destruction. Rest pain in ischemic foot can be relieved by successful revascularization and paravertebral lumbar block. If that fails, opiates too have to be given for pain relief, and below-knee amputation is the last resort. Urgent treatment in ischemic ulcer: if there is danger signs, redness or swelling of the foot, cellulitis or discoloration or crepitus gas in the soft tissue, and a pink painful pulses foot without gangrene, even indicates critical ischemia. Urgent treatment include bed rest, IV antibiotics. It is necessary to cover wide spectrum of antibiotics. Portable therapy consists of amoxicillin, fluoxetine, metronidazole, and either ceftazidime gentamicin to cover negative organisms. Urgent treatment can be adapted when results of culture are available. An emergence of MRSA is problem. Available treatment include intravenous clindamycin, vancomycin, and teicoplanin. Intravenous insulin pump may be necessary to control the blood glucose and surgical debridement to drain pus and abscess cavities and to remove all necrotic and infected tissue and to remove devitalized infected bone resulting from osteomyelitis. If necrosis has developed, if the disease reamputation is necessary. Skin grafting is needed after granulation tissue has developed, which accelerates wound healing. Wagner's classification 0 is impending ulcer, intact skin, 1 superficial, 2 deep to tendon, bone or ligament, 3 osteomyelitis, 4 gangrene of toes or forefoot, 5 gangrene of the entire foot. Antibiotic selection. Any antibiotics may be associated with Clostridium difficile, especially cephalosporins, clindamycin, and coamoxicilla, quinolones, and peptides. All beta-lactam quinolones and microlides are associated with increased MRSA. In all these cases, treatment of infected diabetic foot lesion should be focused on narrow spectrum, preferably by culture. In severe infection only, we will give antibiotic empirical therapy. For 1 to 2 weeks of therapy is usually needed. Common organisms are Staph aureus, Pseudomonas, and Enterobacteria, followed by coagulase negative staph and Enterococcus and final anaerobes. MRSA, linezolid is active against MRSA, has well documented peripheral optic neuropathy and lactic acidosis and bone marrow toxicity. So it requires full CBC monitoring and is subject to potential drug interaction include serotonin syndrome when prescribed with SSRIs and reduced concentration when prescribed with rifampicin. Also affect insulin sensitivity to alter the risk of hypoglycemia. Novel cephalosporin cefpralon has shown efficacy in intravenous treatment of gram-positive include MRSA has been effective treatment in diabetic foot infection. Levofloxacin has similar oral bioavailability and bone penetration properties compared to ciprofloxacin, but cautiously used in patients with risk factors for QT prolongation include co-prescription with some antidepressants and pre-treatment and follow-up ECG are advised in these circumstances. Chronic kidney disease is a common comorbidity in people with diabetes, which also increase the risk of foot ulceration. Direct nephrotoxic effects from the agents with narrow therapeutic index such as gentamicin require close monitoring. In addition, side effects such as hyperkalemia occur more frequently in people with reduced renal function. Consideration of renal function is therefore encouraged both empirical antibiotic choice and dosing in those with CKD. And authors recommend a maximum 4 days of empirical gentamicin. OPAT, outpatient intravenous antibiotic therapy. Once the individual is clinically stable enough, then we can start OPAT. What are the key points? Samples for microbiology should obtain from all clinically infected ulcer prior to institution of antibiotic unless septic. Antibiotic therapy is to treat infection, not the ulcer. Empirical antibiotic depend on the severity and clinical suspicion of the organism and availability of positive cultures, awareness of the patient drug tolerance or toxicities and comorbid factors, age, renal function, body mass. Initial antibiotic regimen should be tailored and duration of therapy should be assessed clinically and discussed with a specialist clinical microbiology. Leucon toxicity should be considered with specific agents and actively monitored. Conclusion. Beware of potential side effects and drug interactions with rifampicin, doxycycline, cipro, and metro, and linezolid. Is there a suspected infection? Then obtain good quality microbiology specimen, assess the severity of infection, mild, moderate, or severe. Are they antibiotic naive? Do they have penicillin allergy? Could there be MRSA or any other special circumstance? Choose empirical antibiotic therapy. Amend the therapy based on the sensitivities and clinical response.
In case of antibiotic naive, fluoxetine with metronidazole with or without, and severe fluoxetine plus clindamycin plus or minus gentamicin. In non-antibiotic naive, moderate augmentin TDS and peptides 4.5 QDS. And in the case of MRSA is there, the antibiotic selection will be higher grade of antibiotics as shown in this video. And OPAT, these are the antibiotics, and duration for severe 7 to 10 days of IV, and switch to oral for 14 days. For osteomyelitis, more than 6 weeks treatment is needed.
So don't ask for a more favorable wind. That's like wishing something that's not going to occur. Don't ask for better seed and soil. All you got's what's available. Don't curse what you got. On this planet, all we got's the seed that's here, the soil that's here, the miracle of life that's here, the opportunity that's here. That's all we got. Wherever you've come from in your country, the economy you got, that's all you got. In America, our economy, that's all we got. Don't criticize all you got. The key is to set a better sail and turn what you've got into the miracle of your future. Don't wish it was easier. Wish you were better. Don't wish for less problems. Wish for more skills. But here's what you got to do in your own personal development, your own personal growth, and that is just get better at handling the winters. You can't change the winter. You can't change the seasons, but you can change yourself. You say, well, what can I do about the upcoming winters of my life, the challenges that I know I'm going to face? Here's what you can do. You can get wiser and stronger and better.